Hello everyone and welcome to today's class of Endocrine Physiology. So in today's class we are dealing with the adrenocortical hormone, that is the mineralocorticoids. As you know, we are following the CBME curriculum of competencies and objectives. I am Dr. Swati Tikare. The competency is 8.2 under adrenal cortex, the mineralocorticoids. The objectives: by the end of this class, the student should be able to describe the biosynthesis of mineralocorticoids and the adrenal sex steroids. Describe the mechanism of action, regulation, and actions of mineralocorticoids, and also the actions of adrenal sex steroids. Lastly, we will discuss the applied aspects of these two hormones, that is the pathophysiological basis for Conn syndrome, congenital adrenal hyperplasia, and adrenogenital syndrome. So these are our objectives for today's class. So let's begin. So we have seen this diagram even before when we discussed glucocorticoids. So as you know, this is the adrenal cortex from outside inwards, the outermost layer, that is the fibrous capsule. Then we have the zona glomerulosa, which is lying parallel to the fibrous capsule, all the cells. Next, we have the fasciculata and the reticularis. Inner, we have the adrenal medulla. So now we are concentrating on the hormone produced by the zona glomerulosa, that is the mineralocorticoids. They secrete the mineralocorticoids aldosterone and deoxycorticosterone. They have yet another important function, the zona glomerulosa, that is that it renews the other layers of the adrenal cortex. Okay, the cells of fasciculata and reticularis are renewed by the zona glomerulosa. Coming to the mechanism of action, we will see with the biosynthesis first. Synthesis of mineralocorticoids in zona glomerulosa of adrenal cortex. So we begin with acetate. We have seen all these steps even when we discussed the glucocorticoids. In the presence of ACTH, as you know, ACTH is the hormone produced by the anterior pituitary and it is tropic to the adrenal gland. So in the presence of this ACTH and angiotensin, acetate is converted to cholesterol. Cholesterol, in the presence of the enzyme cholesterol desmolase, is converted to pregnenolone. Okay, remember this enzyme cholesterol desmolase is present within the mitochondria, and the cholesterol has to reach the mitochondria, and there this enzyme can convert it into pregnenolone. Okay, so this is that. So once pregnenolone is formed, 3-beta steroid dehydrogenase converts it into progesterone. The next step is the activated by the another enzyme 21-beta hydroxylase, converting it into 11-deoxycorticosterone. Further, 11-beta hydroxylase converts it into corticosterone. And aldosterone synthesis and angiotensin 2 are required in conversion of corticosterone to 18-hydroxycorticosterone and ultimately the aldosterone. Okay, so it would be important for you to remember all these enzymes because deficiency of any particular enzyme results in blockage of that pathway at that level and excess of the precursors, and a lot of changes or actions are there based on where there is a blockage. Okay, so you have to remember all these enzymes and the pathway of the biosynthesis of the, whether it is the mineralocorticoids, glucocorticoids, or the adrenal steroids. So this is the biosynthesis. Coming to the mechanism of action. So as you know, the aldosterone is a steroid hormone. So it is a lipophilic and hence it is capable of entering the target cell, inside the target cell, and it binds to the receptor, cytoplasmic receptor, and forms the hormone receptor complex. The hormone receptor complex enters the nucleus, binds to a particular area of the DNA, and then it produces the mRNA, okay, which is related to a particular protein, which is like code for a particular protein. And when this mRNA moves out into the cytoplasm, the new protein is synthesized here in the endoplasmic reticulum. So thus this protein will bring about the actions that are to be brought about by these steroid hormone, that is aldosterone in this case. Okay, let's quickly reinfect the steps of the mechanisms of action. So this whole thing, because it is mediated through the DNA, through the mRNA, we call it as a genomic action. The steroids basically have the genomic action only, but they have some minor non-genomic actions also. Okay, so in aldosterone, the genomic action here, the steps, as we said in the figure, just let's go through. Lipophilic hormone crosses cell membrane, binds with intracellular receptor, forming hormone receptor complex. The hormone receptor complex then binds to specific sequence of nucleotide bases in the DNA called hormone response element, HRE, okay, which is specific for a particular hormone. Results in the synthesis of messenger RNA, that is mRNA, and which ultimately causes the biosynthesis of a specific protein. So this genomic action of the aldosterone is basically happening in two ways. One is the rapid effect, and is the slow effect. Okay, so basically you remember that aldosterone, when we learn the actions, we will also know that aldosterone's basic action is on the mineral metabolism or maintenance of the minerals levels in the plasma. It causes reabsorption of sodium, okay, in the kidney. We will see the details later. But here, what is the rapid effect? How does it bring in the rapid effect? It increases the insertion of ENaC, that is epithelial sodium channels, okay, to the cell membrane. So these ENaC channels, you will see they are within the cell before, but once aldosterone comes, they come to the cell membrane so that they will allow the entry of the sodium. So first rapid action is whatever available ENaC channels are there, they are put into work. They are set to the cell membrane. The flow effect is they increase the ENaC synthesis. Okay, this is the slow effect. The non-genomic action of the aldosterone is that aldosterone binds to the cell membrane receptors and increase the sodium-potassium exchanger activity. Okay? So basically what we said, the genomic action was it was entering, the aldosterone was entering inside and it was producing a particular new protein. What was that new protein? ENaC channels. Okay, that was the genomic action. The secondary action is it is binding on the whichever the target organ, target cell is there on the cell surface itself and also increasing the sodium potassium exchange activity. So these are the mechanism of action of the aldosterone. Coming to the actions of aldosterone, what are the physiological actions? Mainly it acts on the regulation of the plasma electrolyte levels. Its major action being on the electrolyte. So naturally, it is the kidney, okay, especially on the DCT and collecting tubule, distal convoluted tubule, and in the collecting duct or collecting tubule. Two types of cells present there, as you know already, are the principal cells and the intercalated cells. Let me just explain this diagram first to you. So this is a part of the nephron, that is the DCT or the CT. Okay, so these are the cells lining, and this is the lumen within the DCT. This is the lumen where whatever GFR fluid is flowing here, and what needs to be reabsorbed into the body will be reabsorbed into the cells. Then it will send it into the interstitium. Okay, this is the interstitium. From there, it will go to the blood. Okay, what is not reabsorbed or secreted into this lumen will be excreted via the urine. So in the principal cell, in the presence of aldosterone, what is it doing? There are several ENaC channels first within the principal cell. What it does, it will put it up lined up here on the luminal side. Okay, once it lines up, more and more sodium is entering into these inert channels, and more inert channels are also produced and which will be lined up, which will cause increased sodium absorption. Okay, while doing that, what else it is doing is it is also activating the sodium potassium ATPase here, okay, in the basal side. So sodium, which was reabsorbed, is being pushed into the interstitium, into the blood. It is getting reabsorbed, whereas potassium is entering inside here. And this potassium is also secreted. And ultimately, it goes out and gets excreted in the. Okay. Another thing happening in the intercalated cell is the secretion of hydrogen. Okay. Whereas bicarbonate is reabsorbed, hydrogen is being secreted. Chloride is also reabsorbed, okay, in exchange. So overall, you know that sodium is getting reabsorbed, chloride is getting reabsorbed, bicarbonate is getting reabsorbed, whereas potassium and hydrogen are getting secreted. So let's just see the text. What is it going to do? The actions of the aldosterone, when so much of sodium is getting reabsorbed, it is going to increase the sodium level, serum sodium level, due to increase in the absorption of sodium from principal cells of BCT and collecting that. One. Second, it increases the absorption of sodium in other glands also, like the salivary glands, sweat glands, and in the GIT. All the secretions of GIT, more and more sodium is getting reabsorbed. They are not secreting it. Okay, so everywhere it is reabsorbing sodium. Now coming to potassium, what's happening? Sodium is reabsorbed in exchange of potassium and hydrogen. So potassium and hydrogen are getting secreted. So there is decrease in the serum potassium level and it is excreted into the urine, potassium. Okay, so basically, so aldosterone action is increasing sodium level, decreasing potassium level, and once sodium is reabsorbed, chloride is also reabsorbed. They will cause more water to be retained, and hence they will increase the body fluid level. Okay, so we have increased ECF, increased blood volume, and increased blood pressure whenever aldosterone is acting in. Okay, so these are the actions of the aldosterone. Next, what will happen to the acid-base balance? Normal aldosterone levels helps in maintaining the acid balance level. But if aldosterone is present in excess, you can understand more and more hydrogen ions are getting secreted, right? Hydrogen ions is leaving the body, whereas bicarbonate is getting added to the body. So alkali is getting added, acid is getting secreted. So there will be metabolic alkalosis if there is excess aldosterone. Whereas the opposite will happen if there is deficient. Hydrogen will be left in the body, causing acidosis. Okay, we will see the same in the text. Excess aldosterone, more sodium reabsorbed, potassium and hydrogen are excreted, resulting in metabolic alkalosis. Okay? Whereas in deficient aldosterone, less sodium reabsorbed, less potassium and hydrogen is excreted. A lot of them are in the body. So it will cause metabolic acidosis. So if we understand the basic things, it will be very easy for us to put the same principle in the applied aspects when we learn about excess or deficiency of aldosterone. Okay, so we move on to the next. How is this aldosterone regulated? Okay, let's just recall some basic principles before we just jump into how it has regulated aldosterone. Okay, what are the basic principles how any particular hormone is regulated? The first and foremost you can recall is the negative feedback mechanism. I hope you can recall. What do we say? That if suppose we are talking about thyroid hormones, okay, we have thyroid TSH being secreted from anterior pituitary. Above that, hypothalamus is releasing TRH, thyrotropin releasing hormone. So thyrotropin will stimulate TSH, TSH will stimulate thyroid hormones. So when thyroid hormones are more, they will inhibit their TSH, if it is less, it will stimulate by negative feedback mechanism. So this kind of negative feedback mechanism, one way of regulating the hormone. Okay, so for aldosterone, what is the stimulant? So you can recall that for the aldosterone, the stimulant is ACTH. Okay, adrenal corticotropic. Or it is the same for the Cushing's, for the glucocorticoids, for the mineralocorticoids, and also the sex hormones. Okay, the basic stimulant about which is there is the ACTH, which is released by the anterior pituitary. Okay, so we have one mechanism. We have understood now. There is a negative feedback mechanism from the hormone. The second way, if you can recall, for any hormone to be regulated is the ion, the nutrient, or whatever the effect on which it is having an effect, that itself will regulate. Okay, like sodium for glucose, insulin. For insulin regulation, we know glucose will regulate insulin. If glucose is more, insulin will quickly be released to reduce it. If glucose is less, then insulin is not released. So that is the nutrient which is covering. So definitely here aldosterone is having its effect on sodium and potassium. So sodium and potassium will have a role here for regulating. Okay, so once I have just tried to make you recall, as soon as you tell regulation, you should be having some basic principles. What could be the things? Because we may not be able to always recall everything by just following for every single hormone. The basic principles we should be knowing. So let's see some stimulants for aldosterone secretion. What is the action of aldosterone? Aldosterone is reabsorbing sodium. So what do you think? If sodium is less, then it is going to stimulate the release of aldosterone so that it can more and more can be there, right? So hyponatremia, when sodium levels go down, they stimulate aldosterone secretion. Next is hyperkalemia. If there is excess hyperkalemia, aldosterone is stimulated. Next, ACTH. Okay, this is what we were talking about, the negative feedback mechanisms. If the aldosterone is more, then ACTH will inhibit it. But if the reverse, it can happen later. Okay, so in addition, if ACTH is also released in times of stress, like surgery, trauma, hemorrhage, and all these conditions. So wherever there is stress, there is ACTH. And when there is ACTH, it will cause the release of all these adrenocortical hormones, including aldosterone. Okay. So stress is an important stimulant for release of aldosterone. Same for glucocorticoid. Okay. Lastly, we have a different mechanism here for regulation of this particular hormone that is called as renin-angiotensin aldosterone mechanism. Okay. So let's see this renin-angiotensin mechanism a little bit in detail. Okay. So again, don't get overwhelmed with the so many pictures over there. It's very simple. So we'll start from this point where it is stimulating. So the name of the system is renin-angiotensin-aldosterone pathway or system of regulating aldosterone. So when is the system activated? So whenever there is less sodium, whenever less sodium means less fluid in the body, dehydration, or when there is a decreased DCF, decreased DCF means decreased blood pressure. That means there is a hemorrhage or something like that. So all these things are going to trigger this particular pathway. Okay, so we begin with one, that is what are all the things that are there? Dehydration, sodium deficiency, hemorrhage. So any of them causing decrease in the blood volume, decrease in the blood pressure, they will stimulate the juxtaglomeralular apparatus, okay, the JGA. And what does it do? It releases an hormone called renin. Okay, and once renin is produced, the renin converts angiotensinogen, that is a protein that is present in the liver, to angiotensin 1 and angiotensin 2. Okay, course, some converting enzymes are required. It has to pass through the lung. Everything is there. But ultimately, the renin is also essential for converting angiotensinogen 1, angiotensinogen to angiotensin 1. Then that is converted in presence of angiotensin converting enzyme in the lung to the angiotensin 2. Okay. Now, our important participants in this particular pathway. First one is renin, okay, which was released in response to decreased sodium, decreased DCF, decreased blood pressure. Okay, renin was released. And what did this renin do? It converted angiotensinogen to angiotensin 1 and 2. Angiotensin 2 is again the important job. Two important jobs it does. First thing is it acts on the adrenal cortex and causes production of increased aldosterone. Okay, so aldosterone is regulated in this way. Increased aldosterone will act on the kidney, increase sodium absorption, water absorption, and hence increase blood volume, and it will result in bringing the blood pressure, everything normal. Okay, of course, this is in the big picture, but what for us we were interested in the regulation of aldosterone secretion. We have this renin and angiotensin increasing the aldosterone. Okay, the other function of angiotensin 2, just for the completion sake, angiotensin 2 has a pressor effect. That means it causes vasoconstriction of the arterioles. This vasoconstriction also will increase the blood pressure. Okay, this is how we, in addition to increasing the aldosterone, this is going to increase the sodium level, and it will also decrease the potassium level. Okay, this is one more stimulant which has been shown, that hyperkalemia will also stimulate the adrenal cortex to release aldosterone. Okay. So that's about the renin-angiotensin aldosterone pathway regulating the aldosterone mechanism level. Next, coming to the applied aspects of mineralocorticoids. So we begin with the primary hyperaldosteronism. So what is this primary and secondary? Already you people know that. What is primary? Anytime the problem lies in the particular organ which is producing that hormone, we call it as primary. If the problem lies outside that particular organ, then we call it as secondary. Okay, so here when we use the word primary hyperaldosteronism, what is the problem? Must be in the zona glomerulosa itself. So there is excess production of aldosterone, probably due to an adenoma in the zona glomerulosa. And this primary hyperaldosteronism is also called as Conn syndrome. Okay, so the cause is presence of an aldosterone producing adenoma. What happens? There is excess production of aldosterone, and the same things repeat. Whatever actions you know of the aldosterone, same things are happening here. Let's see what's happening once again, just for the completion's sake. So aldosterone, what does it do? It increases sodium reabsorption. A lot of sodium is reabsorbed, means it will also cause water retention. It will increase the ECF volume, and hence it will cause hypertension. So hypertension can, Conn syndrome can present as hypertension. Okay, so we cannot assume that every hypertension is because of any cardiac cause or something like that. It could be a renal cause, it could be a hormonal cause. So we have to evaluate always. Okay, so these are the features of Conn syndrome: hypernatremia, increased ECF volume, hypertension, then potassium is lost, so there is hypokalemia. Okay, let's see some of the features here written. So we have hypernatremia. A lot of sodium is reabsorbed in the saliva, sweat, and secretion. So in the secretion itself, sodium is reduced. It is reabsorbed in the body itself. So saliva, sweat, and GI secretion have less of sodium. There is hypertension. Hypokalemia can present as muscle weakness and hypotonia. Slight increase in ECF volume, but there is no, endlessly, because aldosterone is high, the ECF volume does not keep on increasing and cause edema and too much bloating because of a particular reason that is called as aldosterone escape. We will learn what is aldosterone escape in the next slide. That is, even though there is excess of aldosterone, the body escapes from its action and it is not going on increasing the sodium absorption, water absorption, and getting bloated. How it happens, we will see in the next slide. But overall, for this Conn syndrome, what was the cause? The cause was the presence of an adenoma which was producing aldosterone. And how do we treat it? We will treat it surgically by removal of that particular tumor. Now we will just see in the next slide what is the mechanism of this aldosterone escape. So let's go through this flow chart, which will help you to understand. Okay. We begin with presence of primary hyperaldosteronism. That is Conn syndrome. There is excess aldosterone, more of sodium and chloride getting reabsorbed. Hence, there is increased ECF volume. Okay. Let's say the ECF volume has increased by 5 to 15% and blood pressure by 15 to 25 millimeters of mercury. If this happens, immediately all the homeostatic mechanisms will start working. It doesn't want this increase. Okay. So how do they do? What do they do? First thing is it increases the GFR. It decreases the sodium reabsorption in the PCT. Okay. If you can recall, in the GFR, 65% of all sodium and water are reabsorbed in the PCT. Okay. So this is decreasing. And all this is happening because once the blood pressure and the ECF increases, this is sensed by the certain receptors which are present in the heart, okay? Specifically the right atrium. And they produce an hormone which is called as the atrial natriuretic peptide, okay? ANP. Atrial natriuretic peptide. As the name suggests, it is being produced by the atria. Natriuretic. It is secreting or it is excreting more of sodium and fluid. Okay? Uresis means diuresis is loss of fluid. Okay, so this is a hormone which will cause loss of sodium, loss of fluid. Okay, so ultimately, this particular hormone will override the action of aldosterone and excretion of both salt and water begin to happen. Okay, what was aldosterone doing? Going on absorbing sodium, absorbing water. But the opposite, it is this hormone is causing excretion of both sodium, chloride, and water by pressure natriuresis, pressure diuresis, and also by this hormone. Okay, so even in the presence of excess aldosterone, the actions of aldosterone are escaped, and this is called aldosterone escape. And in Conn syndrome, the elevation of the ECF volume is only to a small extent, and there won't be any edema. Okay, so this is a very important aspect. So aldosterone escape could be asked to you in the Viva or its MCQ part on this place. Then next we move on to differentiating between primary and secondary hyperaldosteronism. Okay, so first we will go to the causes for primary hyperaldosteronism is called as Conn syndrome. Okay, the cause, as we have already discussed, it is the presence of an adenoma in the Zona Glomerulosa, which is producing aldosterone. So that adenoma can be present either in one adrenal cortex or in both. So it could be unilateral or bilateral. Okay, presence of adenoma. Whereas in the secondary, the cause does not lie in the adrenal gland at all. Okay, so it could be due to a renal artery stenosis or chronic heart failure, cirrhosis, nephrotic syndrome. Okay, remember all these are some disorders in which the ECF volume is excess There is circulation is sluggish and it's not happening properly. Okay. Next, we will come back to the features of hyperaldosteronism in primary and secondary. Okay, this part I'll come to the end at the end. We will see the remaining things. Okay, already what we have seen, if there is more aldosterone, it is going to increase sodium absorption. So there is hypernatremia, increased ECF volume leading to hypertension, then hypokalemia, and H plus is released, so there is metabolic acidosis. Okay, so these are the features. Same to same features are there in secondary hyperaldosteronism, hypernatremia, hypertension, hypokalemia, and metabolic acidosis. When we see where it differs is the aldosterone is increased in both again. Okay, where it differs is in the renin. Let's see what is the story about renin, why it is happening. So in primary, we have increased aldosterone, whereas renin is decreased. Okay. Try to recollect here, when was renin stimulated? Whenever there was a low sodium, ECF is not, value is less, hypotension is there, then renin was getting stimulated. But here, nothing of that sort is there. Aldosterone is already increased, ECF is on a little on the higher side, so renin will not be stimulated. So it is natural that renin is at low level. Okay. So in primary hyperaldosteronism, aldosterone is high, whereas renin is low. Whereas coming to secondary hyperaldosteronism, here, please remember the problem lies here in the circulation. So excess of fluid is there in all these conditions. The ECF volume is increased, but still the circulation is not happening properly. So the baroreceptors, the receptors which are able to sense them are sensing that as though it is low. Okay, the circulation is low. So when it tend to feel, the receptors are tending to feel that less circulation is there, less ECF is there, then they will stimulate the secretion of renin. That's why there is increased renin over here. Okay. So the basic difference in is the cause and the renin level. Here it is low, whereas here it is high. This is the difference between primary and secondary. Next, we will move on to the last part. Lack of effective circulation is the reason why there is excess renin stimulation and excess renin. We will move to the last part, that is the zona reticularis. So zona reticularis is over here, and what are they secreting? They are secreting dihydroepiandrostenedione. Okay, that is the androgen, adrenal androgen. And as the name is giving you, I am writing it here androgen because you can understand better that what is its job. It is producing masculinization effects. Okay, the sex hormone. The other estrogen and progesterone are formed very minimally, and uh, that's not important as such. Okay, all the actions that we have is because of the androgen, that is the DHEA. Coming to the biosynthesis, all this is there. You people have already seen this diagram when we saw the glomerulosa producing aldosterone and fasciculata producing cortisol. But we will now concentrate on the zona reticularis. So I will close this part. Okay. So now we will come to what is required here. So the cholesterol is converted to pregnenolone by this enzyme cholesterol desmolase. And remember, this is present only in the glomerulosa. This job has to be done here. Then the pregnenolone is moving out here to the fasciculata by the presence of enzyme 17 alpha hydroxylase converted to 17 hydroxypregnenolone. Okay, this 17-hydroxypregnenolone is converted to dehydroepiandrosterone, DHEA, that is the androgen, by 70-20 lyase. And then it can be converted to androstenedione and to testosterone by these two enzymes, 3-beta-hydroxysteroid dehydrogenase here and 17-beta-hydroxysteroid dehydrogenase. Okay, so this is the biosynthesis. DHEA. Coming to the functions of adrenal sex steroids, the major function is in its fetal life. During fetal life, as I have already told you, the adrenal glands are as big as the kidney in the fetus, and they produce predominantly this DHEA, and this acts as a precursor. They move to the placenta, and in the placenta, estrogen and progesterone are formed. This estrogen and progesterone is essential, and it maintains the pregnancy. So this whole thing is called as the fetoplacental unit, and they are responsible for the maintenance of pregnancy in the fetal life. The adrenal steroid. At puberty, adrenal androgens increase the muscle mass and sexual hair. They help in the increase in the size of the reproductive organs for their development and for their functional state. Androgens also control the development of male physical traits such as deep voice, body and facial hair growth and body shape. Okay, so in normal levels in females, it is at low levels and it does not produce any of these effects. But if they are produced in excessive quantities, they can have certain problems at times, okay, which we will see later. So basically, these are the functions in the normal males and in the fetal life for the adrenal sex steroids. So they have very minimal role to play in the females. Coming to the congenital adrenal hyperplasia. So what is this? As the name says, adrenal hyperplasia. So that means the adrenal gland is increased in size. So it is related to the adrenal glands. Then about here we are specifically talking of the androgens. The congenital adrenal hyperplasia is a group of rare inherited autosomal recessive disorders characterized by deficiency of one of the enzymes needed to specific hormones. Okay, let us try to understand here. So when will the adrenal gland hyperplasia occur? Suppose adrenal hormones, that is basically the glucocorticoids and the aldosterone. Okay, if they are produced in less quantity, by the negative feedback mechanism, ACTH will be increased. Okay, if ACTH is increased, it will stimulate the adrenal growth. Okay, and if by some enzyme deficiency, if further neither aldosterone nor glucocorticoids can be formed, all the excess, what will happen? More and more androgens are formed. Okay, so I think with the next slides you will understand this little more better. At present, please concentrate on just these three lines. That is, congenital adrenal hyperplasia is a group of rare inherited autosomal recessive disorder characterized by deficiency of one of the enzymes that is needed to make aldosterone and glucocorticoids. So let's take a few examples. If there is deficiency of cholesterol desmolase, okay, what was this enzyme required? Please recall it was required to convert cholesterol to pregnenolone. And I said this hormone enzyme is present only in zona glomerulosa. So if this is the beginning level in the biosynthesis of the adrenal cortical hormones, if this is not there, then the rest of the enzyme hormones cannot be formed. And if this is the condition, it is fatal in utero. Okay. And this particular cholesterol desmolase, where is this enzyme present? This enzyme is sitting inside the mitochondria. Okay, so if it has to do its job of converting cholesterol to pregnenolone, there should be some protein which should bring the cholesterol from the cytoplasm into the mitochondria. Okay, and this job is being done by the star protein. Okay, it's named star protein and it transports cholesterol from cytoplasm to mitochondria, where the cholesterol desmolase is present. Now, if this cholesterol desmolase is there in the mitochondria, but if the star protein is not there, which will send that raw material cholesterol to mitochondria, then also pregnenolone cannot be formed, and then also it is fatal in utero. Okay, so these are something which these fetus will not go on to develop or There won't be any, they will not progress until the birth. Okay, some other deficiencies that can occur are 21 hydroxylase deficiency, 11 beta hydroxylase deficiency, and other enzymes can also occur occasionally. Okay, we will now concentrate on, more importantly, the 21 hydroxylase deficiency, which is little more common. Okay, and that is called as adrenogenital syndrome. So let's see here. You don't have to remember all the details, but just remember cholesterol was there, all this pathway was there in one pathway leading to formation of aldosterone, the second pathway in fasciculata leading to formation of glucocortisol, and the third pathway we had in the reticularis forming the androgens. Okay, now this 21 hydroxylase deficiency blocks here, and further it does not form neither the aldosterone nor the cortisol. Okay, so whatever the excess precursors are there, they are all diverted in the formation of excess adrenal androgens. Okay, and thus excess androgens are present here. Let's see some text. The cause for adrenogenital syndrome is deficiency of this hormone, 21 beta hydroxylase deficiency. What it results? It results in deficient formation of aldosterone and cortisol, and the ultimate result is excess formation of adrenal steroids, sex steroids. Okay, so normal adrenal gland, presence of 21 hydroxylase enzyme, normal cortisol, aldosterone, androgen, normal health and sexual development. When it is absent, decreased cortisol, decreased aldosterone. So they had so many major functions. So there are a lot of health problems related to their deficiencies. Okay. In addition, there is increased androgens that is formed. They will give rise to some other phenotypic changes, genital changes, early puberty. Okay. So this is how the deficiency will cause some problems. The excess of androgens will cause some problems. Sum total will be the features of adrenal genital syndrome. Okay, we will concentrate on what is this excess adrenal steroids causing. In genetically female fetus, okay, whenever there is excess androgens, it will result in the formation of a male genitalia. That means the ovaries are there. It is 44XX, but the external genitalia is male, what we call it as pseudo-hermaphroditism. Okay? Genotype is female, whereas phenotype is male. We call it as pseudo-hermaphroditism. Next, if this expresses itself in prepubertal or in prepubertal female or adult female, there are features of virilism. What is virilism? Virilism is any male secondary sexual characterized appearing in a female. Okay, it could be the appearance of the beard, it could be the deepness of the voice, and any other things. Okay, I won't explain in detail. So any male external secondary sexual characteristic appearing in a female is called as the virilism. So same thing if the problem of 21 beta hydroxylase deficiency is always not congenital. It is congenital, but it will express itself at different times. Okay, so if it is happening in pre-pubertal male, so suddenly the male external genitalia increase in size and there is early appearance of the secondary sexual character. Okay, whereas if the same thing is happening in an adult male, then there is exaggeration of already existing masculine characteristics. Okay, so these are different ways of presentation of the adrenogenital syndrome based on the phenotype, whether it is male or female, and on the timing of the appearance. Treatment, replacement therapy for both gluco and mineralocorticoids. Once the replacement is done, the negative feedback is inhibited, no excess ACTH, all these problems will reduce by itself. Okay? So that is what is the treatment. So we have completed now in today's class describe the biosynthesis of mineralocorticoids and adrenal sex steroids. You have to remember all the enzymes. Please go back and practice them. Describe the mechanism of action, the steroids, the genomic action, non-genomic action, regulation via the negative feedback mechanism, renin-angiotensin mechanism, and by the sodium and potassium levels themselves. The regulation we have seen, then adrenal sex steroids, how they are, what is their action, and what are their actions, and in the fetus and in the adult and in the pubertal times, everything we have seen. Then we have also discussed the pathophysiology of Conn syndrome, that is primary hyperaldosteronism, discuss the difference between primary and secondary hyperaldosteronism, and we have discussed adrenogenital syndrome and congenital adrenal hyperplasia. Okay, so based on whether ECTH is increased or decreased, there is also the pigmentation that can be there. So please look into that also among the symptoms. So this is what we have covered for today's class on mineralocorticoids and adrenal sex steroids. So that's the end of today's class. Thank you.